A very good evening, our esteemed guest. I, Nupur Mehta, on behalf of Rajkot Cancer Society, is delighted and honored to welcome Dr. Himang Vasavada sir, a president of Neurosurgeons Association, Dr. Karthik Mora sir, secretary of Neurosurgeons Association, Mr. Gaurang Sanghvi sir, chairman Rajkot Cancer Society, Dr. Khyati Vasavada ma'am, medical director Rajkot Cancer Society, and all other dignitaries present here. Now, I request Dr. Nisha Godasra ma'am to address a welcome note on behalf of Rajkot Cancer Society. Ma'am, please welcome on dais.
Good evening, everyone. At the very onset, on behalf of Rajkot Cancer Society, extend very cordial welcome to all the participants of CME today. This is the sixth CME, which is a part of the larger effort of Rajkot Cancer Society to harness the power of learning and education in today's rapidly evolving profession of medicine. RCS, as you all may very well be aware of, is dedicated to the cause of cancer prevention and cancer treatment with the state-of-art infrastructure and highly competent, experienced, and qualified medical team to support the same. We look forward to a continuous engagement from the eminent professional in onco-neurology field, which will go on long way to alleviate the suffering of cancer patient. On this note, I welcome you all once again and wish you all very happy learning. Thank you.
Thank you so much, ma'am. With no further ados, let's kickstart the meet. Let's dive into a promising schedule, which is for today. Our first speaker needs no introduction. Please give a warm welcome to Dr. Vikrant Pujari to present a topic on basics of spine tumor and management of unusual giant neurofibroma. Please welcome, sir.
Good evening, all seniors, my dear friends and colleagues, and all respected friends. Today I am here at Neuro Onco Meet, and I will be presenting glioblastoma. So glioblastoma, as you know, is a WHO grade 2 variant, is a wild type of IDH variety characterized by a biphasic tissue pattern with alternating areas displacing glial and mesenchymal differentiation. It is inflated in well demarcated mass, often with cystic component and heterogeneous enhancement. It is often difficult to differentiate it from the GBM. The vast majority of gliosarcomas arise from the WHO grade 4 astrocytomas. However, rarely they can arise also from ependymoma or oligodendromas, referred to as ependosarcomas or oligosarcomas. It is seen in the 6th decade of the life usually, and the more male predilection is seen. Histologically, is a mixed tumor of the biphasic differential with glial and sarcomatous components. Proportions of the glial and sarcomatous components vary, may show mosaic pattern. Glial component typically shows typical features of GBM, including pleomorphic astrocytic cells with nuclear mitosis and microvascular proliferation. Sarcomatous component shows densely packed spindle-shaped cells and nuclear can show this variety of morphologies like fibrosarcoma, osteosarcoma, chondrosarcoma, and so on. The key points of diagnosis here are reticular fibers in the sarcoma and GFAP, glial fibrillary acidic protein expression in the gliomas. Here in this we can show the slides which is showing HA and GFAP staining. Immunohistochemical features, as you know, is biphasic growth of the HE staining as well as GFAP staining demonstrating GFA positive glioma component and GFA negative sarcoma component containing tumor spindle cells. Genetic, almost all gliosarcomas are IDH wild type. They are however PT and TP3 mutated, 53 mutated and demonstrated CDKN2 deletion. EGA for amplification is usually not present. CT images you can see, CT scans they can show hyperdense, lobulated, round homogeneous contrast enhancement can be seen with the peritoneal edema. MRI images shows T1 image, weighted images shows hypointense mass, T2 weighted images shows hemorrhagic areas of necrotic, T1 contrast images shows ring enhancement in these cases. Differential diagnosis can be GBM, cerebral metastasis, and can be a meningioma or hemipterangiospericoma. Treatment-wise, gross total resection is usually recommended. Radiotherapy and chemotherapy like TMJ. Recently, immunotherapy clinical trial for glioblastoma or sarcoma has been going on. Like peripheral blood immunologic response to the adjuvant treatment with the immune checkpoint inhibition as a patient with newly diagnosed GBM or gliosarcomas. Prognosis is usually poor in this patient. Mean survival rate is around 6 months to 14.8 months. Here I am presenting one case report. 64 male patient presented with us with the left, right-sided upper and lower limb weakness. Present with GC score 834 M6. Upper limb power on the right side, like upper and lower limb was 2.5. Drowsy, arousable. Here you can see the CT images showing that as well the tumor is on the left side with the perifocal edema is seen. MRI shows contrast enhanced images shows perifocal edema is there. Ring enhancement. Area of hemorrhage and necrosis is seen. Here I am showing the small video where it got a gross total resection of the tumor was being attempted. Here you can see it's a quite vascular, and if the sarcomatous component is more, it becomes like the lobulated mass. It is very rubbery, lobulated mass, quite vascular, well defined plane is there between the brain parenchyma and tumor itself. So total resection was done for this tumor. Here I show the post-op images as well. The total excision of the tumor was being done. For this patient, we got a histopathology. ISC shows gliosarcoma IDH wild type WHO grow at 4 again. So in conclusion, I will say that gross total resection of the tumor is actually recommended. Currently, almost all gliosarcoma patients are guided for RT and chemotherapy following surgery. Radiotherapy has been suggested to improve the outcome of the patient because it may increase the overall survival rate for 2 to 4 months. TMZ has been improved as more effective chemotherapeutic regime. Gross total resection and low expression of Ki index 67 are of the great significance to the prognosis of the gliosarcomas. Thank you very much.
Thank you, Vikrant sir, for the insightful lecture. You have truly set the tone for the upcoming interactions. Let's now move on to our next speaker, who is a radiation oncologist in RCS. Please welcome Dr. Nishant Madhani for presenting on low-grade glioma. Please welcome.
Good evening, one and all. So I am going to discuss about low-grade glioma management, specifically emphasizing or say correlation with molecular markers. So let's begin. For an overview, grade 1 and 2 gliomas are considered as low-grade glioma. Low-grade gliomas have a better prognosis than their anaplastic counterparts. The 10-year OS is 35%. Approx 50 to 75% of grade 2 tumors transforms to high grade in next 6 to 7 years. Location-wise, the frontal being the most common, followed by temporal and parietal domain. So for ease of discussion, we can divide gliomas in 3 subgroups. Today, the subgroups are circumscribed astrocytic glioma, adult type diffuse glioma, and pediatric diffuse glioma. Today, our main focus will be on adult type diffuse glioma, as pediatric glioma is large and a separate entity and needs a separate discussion. So, if we look at 2007 WHO classification, it was totally based on histology. But in 2016, fourth edition classification of WHO came that was based on molecular market, and it came big into the picture. So this was the fourth or maybe 4.5 edition of 2016 classification, where diffuse astrocytoma grade 2, anaplastic, IDH mutant, wild type, GBM, everything was there. But in WHO 5 classification, anaplastic and glioblastoma terms in general were removed. So simplification of classification is like three types: oligodendroglioma, IDH mutant, and 1p19q co-deletion; astrocytoma, IDH mutant, and glioblastoma, IDH wild type. So now also to avoid confusion with alphabets and molecular marker, Roman grading system for grading for 1 to 4 was removed and is now converted in Arabic numerals 1, 2, 3, 4. So by and large, brain tumor diagnosis is evolved from microscopy and histology to IHC and now next-gen sequencing. So if you look here, you see Gopi is very happy as her GBM patient is surviving long, but at the same time her Sasuma is as usual showing her tevar because her grade 2 glioma patient didn't do well. So what was the Johol Gopi did? So she ordered molecular marker studies. If you look at this engine driving brain tumor biology and its diagnosis, IDH, that is isocitrate dehydrogenase, is in the center. The others are 1p19q co-deletion, CDKN2A2B, that is histone, followed by histone 3, third mutation, EGFR. But the important one for low-grade glioma are these two, IDH mutation and 1p19q co-deletion. So IDH mutation is basically present in association with young age and increased overall survival. It's both diagnostic and prognostic marker. Recommended as of now today in all gliomas. Molecular parameter as of now as per WHO 5th classification mandatory. Presence of both variant IDH12 and 1p19q co-deletion defines oligodendroglioma. That will come later on. So patient with IDH mutant gliomas have benefit from radiation and alkylating chemotherapy and relatively favorable prognosis compared to IDH wild type astrocytic tumors with the histology with having same WHO grade. The test commonly we use is IHC, cheaper option. If there is negative R132H IHC study, then Sanger sequences is the next in line for further decision of IDH mutation. So by and large, it has good prognosis. The next one is 1p19q co-deletion. It's the name itself suggests that there is a complete deletion of both short arm of chromosome 1 and long arm of chromosome 19, and is the molecular genetic signature of oligodendroglioma. Almost all oligodendrogliomas with 1p19q co-deletions are also positive for IDH1 and 2 mutation. So it's a vice versa thing. And a predictive marker for response to alkylating chemo and the combination of radiation and chemo, also a good prognostic marker. The test FISH is the test of choice for 1p19q co-deletion study. MGMT promoter methylation, not so important for low-grade glioma. It's a basically prognostic marker, and positivity shows sensitivity to alkylating chemotherapy. ATRX is basically loss of function genetic test. Again, a diagnostic test, relatively favorable prognosis in IDH wild type glioblastoma. Third promoter mutation, again more commonly used for high grade gliomas, having relatively worse prognosis in wild type IDH or GBM, IDH wild type GBM cases with unmethylated MGMT, and relatively favorable prognosis in IDH mutant gliomas. TP53, again diagnostic marker. 80% of IDH mutant anaplastic astrocytomas and GBM have TP53 mutation. So grading is not entirely histological now, since the presence of CDKN2A2B homozygous deletion results in CNS WHO grade 4 even in the absence of microvascular proliferation or necrosis. An IDH wild type astrocytoma with low grade histological features can be considered to grade 4 in the presence of EGFR amplification or third promoter mutation or both combined gain of chromosome 7 and loss of chromosome 10. So all these molecular markers are too much confusion. Let's just simplify it. So if a diagnosis comes with adult type diffuse glioma, for the sake of simplicity, IDH mutation needs to be known. If it is IDH mutant, look for the histology. If histo-suggestive of oligo-like features, then the next thing to be done is 1p19q co-deletion test, followed by histological assessment of mitotic activity and anaplasia. If it is not present, then it is oligodendroglioma grade 2, IDH mutant 1p19q co-deleted, true sense low grade glioma. If mitotic activity and anaplasia are present, then it's grade 3. If the features on histo shows on somewhat like astrocytoma, ATRX and TP53 as we discussed earlier, if it is positive, then go for histological parameters. The first one is no any upstaging features in all of this, then it is astrocytoma IDH mutant grade 2, so no upstaging features. If anaplasia or mitotic activity is present, then it is grade 3 IDH mutant astrocytoma. And the fourth one is astrocytoma IDH mutant grade 4 if microvascular proliferation, necrosis, or if none of the features are visible but CDKN2A2B homozygous deletion is present, then it turns to grade 4 even though in the absence of histological features of grade 4. So this term is now replaced in the place of glioblastoma. What if it is IDH wild type? Again, histological features. The term is diffuse astrocytic glioma, IDH wild type, no elsewhere classified. It was given as a temporary diagnosis if the features are not present from genetic mutational marker, and if EGFR or gain or loss of 7 and 10 chromosome, third promoter mutation is present, even though in the absence of grade 4 histological markers, it will be termed as glioblastoma, IDH wild type grade 4. So we'll look on particularly on these two, oligodendroglioma grade 2 IDH mutant and astrocytoma IDH mutant, because these two only are as far as WHO 5 classification concerned is low grade. So for treatment of low grade glioma, we all know that maximal safe resection whenever possible is first line of treatment and also helps in establishing histo and further molecular study, followed by need of adjuvant therapy. So there are some controversies for low grade glioma in this era of molecular markers, that what is the timing and dose of radiation, and yes, what about chemo? As we all know that there is a proven role of concurrent chemo in high grade tumors, but for low grade tumors, for that it will be in detail discussed in the next talk by Aditi ma'am. So for this is a very old trial from EORTC 22844, which has proven that high dose RT is not required in low grade glioma. So 54 gray is right in 30 fraction is standard of care right now, as there is no difference in OS and PFS with high dose RT. Again, combined study of NCCTG, RTOG and ECOG by Shaw et al. Shows similar result. This trial by RTOG was done for low risk low grade gliomas, those who are having age less than 40 with gross total resection, and it was found that overall survival at 2 and 5 years were excellent without further adjuvant treatment. Another EORTC trial was done on early versus delayed RT, found similar median survival and future malignant transformation rate were similar. The only thing was seizure control was superior in early RT arm. So early radiotherapy after surgery lengthens the period without progression but does not affect overall survival. So to summarize, the recent Pignati criteria for risk stratification is like age more than 40 years, higher tumor grade, tumor crossing midline, presence of neurological deficit before resection, and tumor having more than 6 or more than 6 centimeter size. If two of these are present, then it's considered as low risk. We can go for observation for grade 2 tumors, but 3 or more than that are considered high risk to be treated with EBRT with or without concurrent chemo followed by adjuvant chemo. If you look at the NCCN guidelines, it is also stating that in low risk we can go for observation if the features of low risk are less than 40 or 40 years age or and gross total resection. Similarly, for oligodendroglioma, low risk features for age less than 40 years with gross total resection, observation is an option. So about a brief about radiation technique. As field of radiation is evolved tremendously from 2D era to protons and carbon ion therapy, treatment outcomes and side effects and long-term toxicities are reduced at great extent. Commonly used techniques are from with the use of photons, that is X-rays. These are 3D CRT, IMRT, rapid arc VMAT, IGRT, sometimes in re-radiation, SRT and SRS. Protons, better in some cases, specifically RT, but very expensive. So just to give a brief idea on technical aspect, this picture is showing a pituitary adenoma case with 2D RT. The entire area is receiving the radiation. Similarly, other case of glioma treated with 3D CRT, the red line is showing the actual area to be treated, but brainstem and other part is also getting extra radiation. Now, if we come to the high-end technique like IMRT and VMAT, this is the area is treated perfectly with saving of brain stem, optic chiasma, and other surrounding critical structures. So at RCS, we are treating with all modalities: IMRT, VMAT, SRS, SRT, IGRT. We have 4D CT and HDR brachy also. So thank you. Now both are happy, coming on same page.
Thank you, Dr. Nishan, for that insightful presentation. We are truly grateful for sharing your, valuable insights to this presentation. Let's now move to our next speaker, who is a medical oncologist. Please welcome Dr. Aditi Thanki ma'am for presenting a topic on role of chemotherapy in diffuse low-grade glioma.
Good evening, respected seniors, colleagues and friends. Today my topic of discussion is regarding role of systemic therapy in diffuse low-grade gliomas. So as we have all understood that gliomas are the most common primary neoplasm in CNS in adults. And low-grade gliomas, as Nishan bhai had just mentioned, previously based on WHO grading defined as grade 1 and 2, have excellent outcomes in absence of any significant high-risk feature. And their 5-year overall survivals reach up to 93% in absence of other adjuvant treatment. So as opposed to anaplastic or grade 4 disease, where we have all accepted that adjuvant treatments with radiation and chemotherapy are necessity, for this population, we have to find specific subsets which will benefit specifically with these adjuvant treatments so as to avoid unnecessary toxicities to otherwise very favorable outcome of the diseases. We have to still have remember that these are potentially have a potential to differentiate into high-grade disease, especially the anaplastic gliomas, where 50 to 70% of them are likely to differentiate into high-grade in next 6 to 7 years. There has been evolving management strategies over last few years, especially with advent of integrated molecular diagnosis, ranging from watchful waiting to immediate post-operative radiotherapy or chemotherapy, and now recent targeted therapies, including IDH inhibitors involved in this management. So this is just in nutshell what evolving histological classification looks like. I'll just mention about what subset we are going to discuss here is, which was previously based on histology, defined as astrocytoma or oligodendroglioma or oligoastrocytoma, later on graded with WHO grade 2, now with molecular IDH status followed by ATRX loss or TP53 mutation as well as 1p19q co-deletion, is subdivided into two specific subtypes, either oligodendroglioma IDH mutant 1p19q co-deleted or diffuse astrocytoma, which are IDH mutant. So now coming to the area of interest today in my talk, the role of chemotherapy in CNS tumors. So its role basically depends on firstly the type of tumor and secondly the patient's age. So as we have overall understood that in general chemotherapy has poor efficacy for CNS tumors because of poor CNS penetrability, because of the blood-brain barrier, the transport mechanisms of drug efflux, as well as high plasma protein binding of many of the chemotherapeutic agents, decreasing its volume of distribution in CNS parenchyma. However, there are certain sensitive histologies, which include embryonal tumors like medulloblastomas, ependymomas, high-grade astrocytomas, and of course, lymphomas. The second point is about patient's age. For young children and infants with embryonal tumors or low-grade gliomas or even optic pathway gliomas after resection, we can administer them chemotherapy with an aim of delaying or replacing radiotherapy to avoid drug-related long-term toxicities related to radiotherapy in this vulnerable population. The third important aspect where chemotherapy has role is very large or multilobar disease, where RT fields are expected to be very large, increasing toxicities as compared to focal radiation. For rest of the aspects, chemotherapy mainly acts as an adjunct to other modalities of treatment. So what are the limitations of chemotherapy, especially in low-grade gliomas? Basically, the responses are still disappointing in some of the low-grade gliomas, especially when 1p19q non-deleted disease is present. The treatment is by and large prolonged, ranging from months to a year or beyond, and the systemic side effects always come along. Apart from immediate side effects, there are some long-term side effects including infertility and second malignancy, especially with nitrosurea compounds. So this is how NCCN guidelines currently look like. Nishant Bhai has already discussed this, but I would just like to highlight the chemotherapy part again in this segment. For high-risk patients where we decide to give them treatment, chemotherapy as an adjuvant always comes along with RT as a preferred option. And I would also like to mention about those with poor performance status. In those patients who cannot tolerate radiation with chemotherapy, we have an option of giving them temozolomide as a single agent therapy. So this is just the tabulated form of the same information I just gave. But I would like to highlight another point here regarding recurrent and progressive disease in WHO grade 2, where we have a novel agent mentioned in NCCN guidelines, which is ivosidenib. It's an IDH1 inhibitor, which is useful for IDH1 mutant gliomas. So we'll just discuss in detail about the evidence of these modalities. First is chemotherapy, PCV, a combination chemotherapy with RT. And the evidence comes from RTOG 9802 study, which was a phase 3 randomized controlled trial involving 251 patients. For those with high risk, defined by age more than or equal to 40 years or subtotal resection or biopsy, were randomized to receive either RT alone or RT followed by PCV chemotherapy for 6 cycles every 8 weekly. So the results suggested there was significant improvement in both 5-year PFS as well as overall survival. The overall survival doubled from almost 7 years to 14 years with administration of chemotherapy. However, this came along with some acute grade 3 or 4 toxicities, which also jumped from 9% to 67% with chemotherapy. The greatest benefit of addition of PCV chemotherapy was found in oligodendrogliomas, especially molecularly confirmed IDH mutant 1p19q co-deleted, where hazard ratio of death decreased to as low as 0.21. The second chemotherapy which is most widely used in conjunction with RT is temozolomide. In low-grade glioma, its evidence comes from RTOG 0424 study, which was a phase 2 study, which included 129 patients, and it compared its results with historical controls. Here, as we just mentioned in previous study, the inclusion criteria were for high-risk low-grade glioma were Pignati criteria. Any 3 of the following were considered, if positive, as high-risk disease. The patients received radiotherapy with temozolomide as both concurrent and adjuvant for 12 cycles. And the results showed an improvement in overall survival at 3 years as compared to the historical controls. Of course, with grade 3-4 toxicities of up to 54%. So when we have to choose between these two regimes, there are no head-to-head trials comparing PCV with temozolomide as of now. And both regimes are effective in low-grade gliomas. PCV has an edge because of the phase 3 evidence available in both grade 2 or grade 3 disease. However, temozolomide has an obvious advantage of ease of administration and better patient tolerance, avoiding short-term toxicities with PCV. So it is largely used over PCV in many of the settings. The question of sequencing of chemotherapy with RT is usually radiation followed by chemotherapy, because when chemo is followed by radiation, the tolerance rates are poor. In the setting of very large or multifocal tumors, when chemotherapy alone was used, we have some data to use this with good outcomes. For PCV, there was a study published in 2015 where large low-grade gliomas received 6 cycles of PCV upfront to delay radiotherapy. And median overall survival in this study was 10 years with median PFS of 4 years. For dose-dense temozolomide as a regime used in very large or multifocal tumors, URTC study has shown that dose-dense temozolomide for 1 year versus RT, at least in 1p19q co-deleted oligodendrogliomas, did not show any significant PFS disadvantage. However, overall survival data is not present. Other chemotherapy regimes apart from these two commonly used drugs, for pediatric brainstem gliomas are vincristine with carboplatin in weekly dose, monthly carboplatin or etoposide in combination with these drugs. Also 6-TG with PCV is a viable option with increased toxicities. Now the last part of my discussion is about newer targeted therapies. And I would like to start with a discussion on early published data on IDH inhibitors in Indigo trial. Now this was a phase 3 randomized controlled trial involving 331 patients, and the inclusion criteria were very clear. Residual or recurrent grade 2 IDH mutant gliomas without any prior therapy except for surgery were included, and they had all measurable non-enhancing disease, measuring more than or equal to 1 centimeters in 2 dimensions with good performance status and were being considered for watchful waiting. So not those who had significant symptomatic disease. Here the drug used was vorasidenib, which is an oral brain penetrant IDH1/2 inhibitor at a dose of 40 milligrams per day, and it was compared with placebo. And in the results, the drug showed significant improvement in median PFS, more than doubling of PFS from 11 months to 27.2 months, with significant delay in time to next intervention with hazard ratio of only 0.26. The grade 3-4 toxicities were 22.8% in the drug arm versus 13.5% in placebo arm, mostly in form of raised SGPTs and were manageable. So there are some other IDH mutants also which are approved in other indications, including IDH mutated AMLs, MDSs, and are in investigation currently for gliomas, which includes ivosidenib, as I just showed, has got its place in NCCN recurrent or progressive gliomas. Now, apart from IDH inhibitors in pediatric low-grade gliomas, where there is MAP kinase pathway activation, we have inhibitors of MAP kinase also. However, currently when to use these drugs is controversial, whether in upfront setting or at progression. Selumetinib and trametinib are MEK1/2 inhibitors, and they are recommended for both NF1 associated or sporadic optic pathway gliomas. Even Vemurafenib, a BRAF inhibitor, is useful in this setting. However, MEK inhibitors are preferred over BRAF inhibitors in order to avoid the paradoxical activation of MET kinase pathway. Angiogenesis inhibitors like bevacizumab and immunomodulators like lenalidomide are also useful in this setting. Just to complete the list, we have mTOR inhibitors like everolimus, which has been used and now frequently replacing surgery in subependymal glial cell astrocytoma and even in recurrent pediatric low-grade gliomas, and NTRK gene fusion tumors when present, larotrectinib and entrectinib are useful. However, these drugs are not currently available in our setting. So my take-home message from this talk will be, for low-grade gliomas, evolving risk factors based on clinical, radiological and molecular aspects need to be considered before deciding immediate treatment versus watchful waiting. IDH inhibitors are a promising new strategy for improving PFS in measurable, non-enhancing residual disease, delaying both radiotherapy and chemotherapy and their toxicities. And newer targeted therapies offer additional treatment option in recurrent or resistant disease. I thank you all for your patience.
Thank you, ma'am, for that insightful aspects for low-grade glioma. Well, I believe that by identifying interpersonal team approaches and strategies, we can overcome. Will definitely gonna improve, the outcomes for in adults and pediatric patients. Now we'll be moving towards one of the highlights of our event, that is a panel discussion. So for the topic on for panel discussion will be on low-grade glioma, and I would like to call upon on dais Dr. Deepti Pradhan ma'am as a moderator. She is a radiation oncologist in RCS. Please welcome ma'am. Now moving ahead, I would like to call upon our esteemed panel members. Please give a warm welcome to Dr. Gauravi Dhruva ma'am. Please ma'am, welcome on dais. Dr. Himanshu Jalavaria, sir, please welcome on dais. Dr. Himang Vasavara, sir, please sir, welcome on dais. Dr. Hina Rathod, ma'am. Dr. Shweta and Dr. Jimmy, who is to bring a unique perspective to the table. Please sir, welcome and please take your seat.
Very good evening to all of you. So without delaying, we will start the interactive session. Welcome all panelists. Let's move to the case. So this is a 33 years old female presented with episodes of convulsion in May 2022. There was no headache, vomiting or neurological deficit. So my question to the neurosurgeon, Dr. Hemant Besawada sir, how will you approach this case?
See, according to recent protocol in neurosurgery, my all colleagues will agree. Even if there is a single convulsion, one has to go for MRI. Agreed? That is the first step we should proceed. We will advise patient to go for MRI brain and will request radiologists that if the contrast is needed, if something turns out, at the same sitting it should be done.
Okay. So MRI brain is the imaging modality of choice. Sir, can we advise CT brain?
See, according to recent guideline, CT is not that much good as MRI in case of epilepsy. CT scan, if we go for it, then ultimately we have to go for MRI any second stage if something turn up. So patient has a double burden. First pay for CT scan and then go for MRI. Many small lesions or edema like white matter are escaped in CT scan. So I would prefer to go straight away for MRI scan.
So MRI brain is the imaging modality of choice. Now this is the MRI images. So Himanshu sir, Can you please read the MRI images?
What we have seen here is infiltrative type of intraaxial lesion in right parietal lobe with minimal perifocal edema, and the spectroscopy is showing raised choline with reduced Na, suggestive of proliferative type of neoplastic lesion, probably a primary glioma.
So MRI brain with spectroscopy showed well-defined irregular space-occupying lesion involving the right post-central parietal and angular gyrus of size 43 by 45 by 38 mm, and there is ill-defined non-enhancing cortical and subcortical hypointense lesion on T1 images, heterogeneously hyperintense lesion on T2 and FLAIR images. So MRI spectroscopy shows elevated choline and creatinine ratio suggestive of proliferative lesion, and there is elevated lactate and lipid peak. So what is the provisional diagnosis?
Provisional diagnosis would be a primary glioma.
Okay. So provisional diagnosis is low-grade glioma. Himang Basavada sir, what will be your plan?
See, of course, both the previous speakers stressed on the total resection of the tumor. At the most, subtotal, and goal is to keep the tumor tissue less than 1 centimeter. So that should be the plan. Get the rid of the tumor by doing craniotomy, excising completely tumor, let the little white tissue also, if there is no demarcating plane, should be lost, because it is not a very important area, it is quite posterior parietal. So under electrodiagnostic modification in the control, we can remove almost complete tumor, send for histopathology, and then refer to Dr. Thanki or Dr. Madhani. This is my plan.
Sir, very frequently we come across different terms like near total excision, subtotal resection, partial resection, stereotactic biopsy. Sir, can you please explain just for our knowledge?
See, usually the goal is total resection when the brain area is indispensable. Say for occipital cortex, posterior parietal cortex. If it is on the motor strip, then we are much on the back foot. Of course, there are now intraoperative electrodiagnostic modalities available. But however, at that time, some tissue is left, and that goes for subtotal. Biopsy is a biopsy, stereotactic biopsy we can perform, definitely yes, but then it can be converted if the tumor tissue is favorable, the patient condition is not moribund and can sustain the surgery as well as CPRT, then the better is the total resection or subtotal resection. See, previously when anesthetic modalities were not good, when the electrodiagnostic intra-op monitoring was not possible, at that time, many a times after opening, Dr. Model Rajendra Bhai will agree with me, even Nimish, we leave it, we take the biopsy, we feel that enough, whatever decompression is done, we do it and leave the patient alone. But that is the story of old days. Now the goal is total resection.
So the patient who undergone right parieto-temporal craniotomy and near total excision on 10th May 2022. Histopathology report revealed oligodendroglioma, WHO grade 2. So, Madam Gaurav with you, Madam. What are the most typical features of oligodendroglioma, histopathological features of oligodendroglioma?
Histopathologically, closely packed cells will be seen. The nuclei will be monotonous And the main feature we will see is a fried egg appearance in histopathology. That is a halo around the nucleus, and there will be the capillaries will be like chicken wire capillaries will be there. So this will be the features, and microcalcification is also present. So these are all the leading features for oligodendroglioma.
See, almost every neurosurgeon will agree. While removing the oligodendroglioma, we always have a gritty sensation because of calcification. Even it is visualized on CT scan also calcified area. And best source is when you remove the tumor oligodendroglioma, we get a gritty sensation. So we can suspect intraop only that it is oligodendroglioma.
So now the patient being referred to radiation oncologist. According to current WHO classification, what further investigation is mandatory to complete the diagnosis? Dr. Shweta.
As we have reviewed the case, it is on radiological imaging, it was primary glioma. We still don't have a proper histopath. So we need to know whether it is low grade, high grade, or whether it is oligo, estro. So we need to go for IDH mutation.
Yes.
And if IDH mutation is there, then we need to also go for 1p19q codeletion to see whether it is oligodendroglioma. And if it is negative, then it could be astrocytoma too.
So, Gauravi madam, which method you prefer? DNA sequencing, fish analysis, or IHC for 1p19q correlation and IDH mutation status?
See, firstly we will see, go with IHC, and we'll see for this IDH mutation, and then this gene sequencing for this co-deletion 1q19q. So, firstly immunohistochemistry.
So final diagnosis, in our case, IDH mutant, 1p19 co-deletion positive. So according to WHO 2021 classification, final diagnosis is oligodendroglioma, IDH mutated, 1p19q co-deleted, CNS WHO grade 2.
Ma'am, one question. Sometimes in the report, we see instead of co-deletion, there is 1p is deleted but 19q is not. So what is its implication?
See, this is co-deletion, so we cannot say it is positive. And other methods we have to try. We have to see for it.
So Dr. Hina, do the patient need adjuvant therapy in this case? How will you decide?
This patient is low-grade glioma grade 2, and I will not go with the adjuvant therapy, radiation or post-op therapy in this patient, as patient comes under the low risk criteria according to the
How you know that it is low risk?
according to the Pignati criteria that previously shown, that the patient's age is less than 40, then histology is oligodendroglioma. Lesion size was less than 6 cm, not crossing midline.
So you will do post-op MRI or not? To know
Yeah.
that whether any
We
residual
will
disease.
do post-op MRI to see whether there is residual disease present or not.
So optimal timing for post-operative imaging.
Post-op MRI will be immediate imaging will be done by neurosurgeon within 48 hours, and for our side we will do a post-op MRI after 2 to 3 weeks.
So this is the post-op MRI. Himanshu sir, there is no residual disease. So are you agree with this?
Difficult to say with the single sequences, but seems to be enhancing post-operative changes and thin ring of possibly residual lesion at the periphery of the cavity.
So what next? Now to the tumor board discussion. A 33-year-old female diagnosed with oligodendroglioma. Post-op MRI shows no residual lesion. So, Dr. Hina, do you advise adjuvant at in particular case?
No, I would not like to give post-adjuvant radiation in this patient as patient
Yes,
comes
you have
under
already told that
the
it is under low risk. Okay. So, this is the Pignatis criteria already we have discussed. Favorable features are age less than 40 years, no neurological deficit, size less than 6 cm, not crossing midline, oligohistology, and unfavorable risk factors are age more than 40 years, neurological deficit present, tumor size more than 66 cm, tumor crossing the midline, and non-oligohistology. But one is to be very careful in assessing residual tumor in diffuse low-grade glioma is non-enhancing. Alter T2 signal might represent residual infiltrative disease. If T2 residual size is 1 cm or more, it is an unfavorable prognostic factor. So, Dr. Shweta, suppose it will come under high risk case. Would you like to give RT or not?
Definitely, as Pignatis score, as we discussed, it categorizes the tumor to low and high risk categories. So, if the patient falls in high risk categories, we should consider the patient for radiotherapy.
Okay, what is the dose you will prescribe?
The dose would be 54 gray at 1.8 gray to 2 gray per fraction. Irrespective of whether there is a residual disease or no residual disease, as discussed by Nishant sir, no dose escalation is required. We can go with 54 gray for the low grade gliomas. There is no benefit when it comes to the clinical outcome. There is no PFS or overall survival benefit.
How much margin you will give?
For delineation point of, as a radiation oncologist, whenever we delineate a brain tumor, we should always have in our mind that we should have a pre and post op MRIs both in our hand, fused with the CT planning images. And for this patient, it is like we need to delineate volumes. First goes for GTV, that is a gross tumor volume, which will include the resection cavity, residual flare if any. And if there is a residual disease, then we should use T1 post contrast images to delineate that. The GTV volumes then can be extended to clinical target volume, which is around 1 to 1.5 centimeter. Clinical target volume will include all our subclinical microscopic diseases. And the CTV is further extended to PTV, which is a planning target volume, which deals if during the treatment if the patient has any setup errors or that we can deal with those margins. So there will be 3 volumes and these were the margins as I discussed.
Okay. So Dr. Jimmy, any role of chemotherapy in high risk cases?
So definitely in the IDH mutated and 1p19q deleted cases, the chemotherapy has in high risk has beneficial role, and in these cases the patient if does not have the subtotal resection or if there is any high risk of chances of disease recurrence as per the Pignatic criteria, then we definitely go for the chemotherapy along with the radiation.
What chemotherapy you prefer?
Generally in our experience is the PCV regimen which has the phase 3 evidence, but the temozolomide which will give the ease of administration as well as the toxicities are limited, and the post chemotherapy quality of life, which is most important factor in such cases, that are better with the temozolomide. In our experience, the temozolomide works well as the phase 2 studies have given the good results for the temozolomide.
Will you give adjuvant chemotherapy after chemoradiation?
So it will not be in the grade 2 tumors, but in grade 3 or grade 4, we definitely like to give the adjuvant further temozolomide.
Okay. So in our case, we have kept this patient for observation till now. We have done MRI in August 2022. The report images are not available. So it was same as May 2022. In July, the patient was on regular follow-up and symptom-free. In July 2023, there was a single episode of convulsion. We have done MRI. there was no new enhancing or non-enhancing lesion. This is the MRI brain. Himanshu sir, can you read this picture?
Comparing the previous images, there is significant reduction in the size of cavity and probably some gliosis surrounding the cavity. Of course, there is some ill-defined hyperintensity which I would like to consider doing a perfusion scan on this.
But we have not done. Again, now we have done MRI in November 2023. The picture is like this.
So it's more or less the same. The post-contrast image still does not show any enhancing component. The T2 and flare images also does not show any increasing flare hyperintensities. On follow-up MRI, I would like to say that the most important sequences for imaging would be diffusion, perfusion, and a flare. So in the current reporting format which we are using, the BT rate, brain tumor rates format, that is, these things are like most important. Whether diffusion restriction is present or has appeared, whether the flare hyperintensities were present or increasing or decreasing, and the perfusion. These are the three most important findings for a follow-up MRI of any brain tumor.
So, what next? Simple, we will jump to give RT. Dr. Shweta? Or we will give chemotherapy?
The patient can be kept on observation for now, and the MRI scans can be repeated as per the guidelines, like maybe for 3 months and then 6 months.
Can we give chemotherapy, Dr. Jimmy? In this case. So, any surgical opinions?
See, nothing. As there is no recurrence, almost nil residual, why surgery?
Yes.
Out of question.
So, we have kept this patient on observation. By taking proper history, we got that patient forgot taking that anticonvulsant on that day only. So, this is the NCG guidelines for flowchart management of low-grade glioma. If the tumor is resectable, then maximal safe resection should be done. After resection, histopathology should be done. Then we will send for 1P19P coordination studies for oligodendral glioma studies. Then if patient is expected to be good compliance to surveillance imaging and favorable pigmentis criteria and low MIB1 index and 1P19Q coordination, so we can observe the patient at A4RT at progression. If patient is, if the tumor is not resectable, only stereotactic biopsy done, or large residual tumors are present, or patient having poor compliance or any unfavorable pigmentis criteria, MIB high MIB1 index, in that case we can give radiotherapy of 54 gray and 33 fractions. Sometimes the patient, we keep patient for observation, but their disease will progress and transform into high grade. Then we can give high dose of radiation of 59.4 gray and 33 fraction with chemotherapy. Okay. So thank you, my esteemed panelists.
Dr. Mogra Sahib, Banne Trivedi Sahib, all colleagues. What I gathered from this presentation to radiologist, once patient is sent to your MRI center, please do all the necessary MRIs. What we are usually finding that MRI brain, patient comes back, radiologist rigs up, there is a need of contrast, or there is a need of spectrometry. See, patient is yours even, is not belongs to, it's not a property of clinicians. So once patient comes to you, you see that there is a lesion, then you do whatever you want to do. It is a direct deal between you and patient. You tell them that you have to pay 7,500 more, but this is needed. Sending patient back, then again sending to radio centers, these are all the practical difficulty usually we come around. So my request and resolution from RNA that once patient is with you, see the tumor in the MRI, do whatever you need. Every neurosurgeon agreed.
Special financial conditions.
That is then look up. They have to talk with the patient. We are not in big. Thank you.